Today I will be presenting on hearing loss in adolescents. Types of hearing loss commonly found in adolescents. Noise-induced hearing loss, also known as music-induced hearing loss, sensory neural hearing loss, speech fluency hearing loss, and high-frequency hearing loss. Hearing loss can be unilateral or bilateral. It can range from borderline to profound. Technology options include none, hearing aids, and cochlear implants. In a study by Harris and Terletsky, 86 children ages 12 to 16 utilized a variety of technology options. 1/3 used hearing aids, 1/3 received cochlear implants before 42 months of age, and 1/3 received cochlear implants after 42 months of age. Causes of hearing loss in this population: sound exposure from personal listening devices, attending concerts, and playing musical instruments. In a study by Martinez-Waldo et al., it was found that 21% of teenagers in Mexico City had hearing loss that was caused by recreational noise exposure. Low to middle class socioeconomic status can indirectly affect hearing. In a study by Ree et al., they found that using earbuds in noisy environments led to bilateral high-frequency hearing loss. In gaming centers, the average noise level is 80 to 85 decibels, which is higher than the decibel level of tolerance established by the World Health Organization, which is set at 75 decibels. Gamers spend anywhere between 1 and 3.5 hours a day at least one time a week in a gaming center. Effects of hearing loss can include, but are not limited to, an increased hearing threshold, decreased amplitude of transient evoked otoacoustic emissions at 3,000 and 4,000 Hz, and an exposure to noise since childhood leads to cumulative effects in adulthood. General information on hearing and hearing loss. An audiologic examination can include questionnaires, an otoscopic exam, tympanometry, standard audiometry, and TEOAEs. TEOAEs can detect subtle changes in the inner ear before hearing loss and can identify those that are susceptible to hearing loss. High frequencies are more sensitive to noise. According to the World Health Organization, the hearing tolerance limit is 75 decibels. Anything greater than 75 decibels is damaging, and around 120 decibels, it can become painful. Providing hearing education. There is a need to implement programs that assess hearing function, identify ear vulnerabilities, and promote positive hearing health behaviors. A hearing conservation program for teenagers needs to be developed, and early detection and avoidance of overexposure to noise needs to be promoted. Academic performance. Hearing loss is associated with lower academic performance. Early cochlear implantation and sign language fluency no longer predict achievement once a child reaches high school. Spoken language has a positive effect on achievement in some domains of education, while sign language has less positive achievement effects in other domains. Cochlear implantation use and support services have little effect on college entrance exam scores. In a study by Harris and Terletsky, the mean reading age of children with hearing loss is several years below their chronological age, and early cochlear implantation does not lead to age-appropriate reading skills at 15 to 16 years old. There are gaps in reading as age increases. Cochlear implant use is unrelated to achievements in learning, vocabulary, and word knowledge acquisition. Attitudes on hearing loss and hearing technology. 75 to 80% of adolescents in Mexico City are aware of secondary effects of noise exposure. However, they continue to place themselves in these environments. In Mexico City, teenagers have a negative attitude toward the use of hearing protection. Individuals that identify with both deaf culture and oral communication express a positive attitude towards CIs, while individuals with a stronger deaf identity express a less positive attitude towards CIs. Perceptions and psychosocial effects. The benefits of hearing aids are countered by a negative stigma. The positive perception of wearing hearing aids as normal leads to more frequent usage of hearing aids. Psychosocial support on promoting a positive hard of hearing identity needs to be incorporated into intervention. Hearing aids can be viewed as stigmatizing, and therefore individuals that need hearing aids may reject to use them. They reject to use them because of cost, technical issues, and psychosocial factors associated with hearing aids. Self-perception of normalcy of wearing hearing aids is the #1 factor in an individual's willingness to wear hearing aids. These are my references, and I hope you enjoyed today's presentation on hearing loss in adolescents. Thank you.